All right, well, good morning and good afternoon, everyone. We will go ahead and get started with our webinar. Welcome to you. Today, we are presenting to you from iGenomics, part of VitroLife Group, PGTM Simplified, Clinical Indications, Technology, and Process Exceptions. We're here to support you and your patients in their journey to have a healthy baby. I'm going to start by introducing VitroLife Group, and then I will introduce our speakers. Go ahead and shift to the next slide. Thank you, Divya. The mission and the purpose of VitroLife Group is to fulfill the dream, to help patients fulfill the dream of having a healthy baby. So we are a publicly listed company with over 1,100 employees. We have a global presence in over 110 markets. iGenomics Group is comprised of two legacy organizations. iGenomics, the one that has been doing PGTM for all of these years. We were founded in 2011, and we are also working with VitroLife Group, which provides IVF medical devices, which was founded in 1994. Our goal and our mission is to support patients in their IVF treatment to maximize the success every step of the way. Go ahead and advance to next slide, Divya. Thank you. So we support patients in their pre-treatment as well as their IVF process and their prenatal and postnatal care. In their pre-treatment, we offer carrier screening and other tests and products. And in the IVF treatment, we offer embryo testing, including PGTM, which we'll be sharing more with you about today. PGTA, PGTA+, that includes ploidy analysis. And we also offer PGT-SR. And then we offer a whole other host of products and services, from medical devices to media to needles to endometrial tests, including Emma and Alice and ERA. And then postnatally, we also offer services like NIPT, mostly in Canada and other markets, but also products of conception testing in the United States. Next slide, please. We have a presence all across the globe. So we have over 1,000 employees globally. VitroLife Group is headquartered in Gothenburg, Sweden, and we serve over 75% of clinics worldwide across all of our products and services. So you'll see that we have various laboratories and product sites in North America, South America, Australia, Europe, and really all across the globe. So now it's my pleasure to introduce to you our speaker panel today. So my name is Dr. Alyssa Snyder. I'm the Director of Clinical Genetics, and I've been on with the iGenomics side since they started in 2011. And then I'm going to introduce our guest speaker. We're so excited to have Dr. Millie Thacker join us today. Dr. Millie Thacker is a triple board-certified specialist in reproductive endocrinology, medical genetics, and obstetrics and gynecology with over 20 years of experience serving as a physician, scientist, entrepreneur, speaker, and content creator. She is the founder of Genome Ally, a telehealth reproductive genetic practice focusing on proactive genetics and preventing genetic diseases through IVF and pre-implantation genetic testing. Additionally, she serves as a reproductive endocrinologist at the Fertility Center in Grand Rapids, Michigan, and is a clinical assistant professor at Michigan State University. An award-winning scientist, she is dedicated to advancing medical research and education and has contributed to the ACOG Clinical Consensus Gynecology Committee and the SART International Committee. Thank you so much, Dr. Thacker, for joining us today.
Thank you.
And next, I'd like to introduce our very own Divya Baxi. Divya Baxi is a board-certified genetic counselor with more than a decade of experience in prenatal and preconception counseling, specializing in pre-implantation genetic testing. Throughout her career, Divya has provided compassionate and educational genetic counseling for patients and continues to be an integral resource for clinicians utilizing genetic testing services offered by iGenomics. In addition to her clinical work, Divya has served as an adjunct professor in the Northwestern University Genetic Counseling Program and as a thesis advisor and mentor to numerous genetic counseling students across the country. She holds a bachelor's in human genetics from the University College London, UK, and completed the genetic counseling master's program at Arcadia University in Philadelphia, Pennsylvania. Divya is passionate about the fertility community and promotes fertility access, advocacy, and testing in her personal and professional life. So Divya, thank you so much for joining us today. We're excited to hear what you guys have to say, and I'm going to go ahead and hand it over to you.
Thank you, Alyssa, for those lovely introductions, and welcome everyone. Thank you so much for joining us. I want to start with an introduction to our topic, PGT. I expect and hope that most of you have some introduction to it already, but really PGT, pre-implantation genetic testing for a monogenic condition, is the option to do testing on embryos for inherited single gene conditions. And families that could benefit from PGTM are usually identified based on a personal or family history of a genetic condition, or more routinely now through carrier screening that may be done as part of the IVF workup or preconception screening. PGTM is really available for thousands of different genes and variants, and all have their various inheritance patterns. And so each case is handled very uniquely. The order of events is usually that we receive a referral from the IVF clinic. We review the case for feasibility. We work on test development. The couple then pursues IVF. Embryo biopsies are sent to iGenomics. We perform testing and provide results that are used to prioritize healthy embryos for transfer. And I want to walk you through that second step of the review that is done once we receive a case, really given that every situation can be so unique. So we've created standard review protocols that a dedicated team of genetic counselors uses to evaluate each new referral. And our goal here is to support the referring provider. Genetics is not always straightforward. Often it is. And in those cases move right along. However, since there are scenarios where it may not be so straightforward, there are special circumstances where we may provide you with additional insights, or really that clinical utility question. Our goal here is to not perform PGTM for cases where we may not reduce risk of a condition. And there are lots of different examples, which I'll go into a little bit and Dr. Tucker will expand on later. So there are some combinations of variants where there may not be any true clinical reproductive risk. So an example would be alpha thalassemia. Say if the couple are both silent carriers of alpha thalassemia, together they don't have a risk for their embryos to have alpha thalassemia. Certain combinations of biotinidase variants or nephrotic syndrome variants, where if both partners carry the same variant, we're not worried. There are also scenarios where the decision to pursue PGTM is just not clear-cut. There may be conditions with variable expression or reduced penetrance or lower risks. Fragile X is a really common example of this. We get a lot of referrals, and there are scenarios where there may be a rather limited chance for the offspring to have Fragile X in the clinical sort of classic scenario that you're imagining. Sometimes when a patient has a more stable copy of their FMR1 gene, say if there are AGG interruptions that make it more stable, then the risk for that allele to expand to a full mutation is sometimes only 1% or a few percent. So in those cases, we really want to suggest that the patient speak with a clinical genetics provider to better understand if that risk is significant enough for them to pursue PGTM. Despite our best efforts, we have had patients who have ultimately regretted doing PGTM. They may not have very many embryos. They may unfortunately have embryos that are all identified to have somewhat of a risk, however slight it might be, and that puts them and the clinics in a really tough spot. Emotionally, it can be really difficult to transfer those embryos with a known risk, and clinically, a lot of providers have policies against transfer of at-risk embryos or additional protocols that may be put in place. There are other types of variants, like variants of uncertain significance, where we simply don't know enough about them. They could be downgraded and reclassified as benign. This is especially something to be aware of in the PGTM space because the results of PGTM are dependent on the results we receive initially. And so if PGTM is performed for a variant that ultimately is not the explanation for the condition in the family, PGTM results are irrelevant. We worry then that an embryo with low-risk PGTM results may be transferred, even if there is another genetic concern at play in the background that we weren't aware of. So our hope is always that these embryos with a VUS are not discarded in case there's more information that comes up in the future. Here we really rely then on expertise from other providers, the patients or their child's clinical team, to evaluate the clinical picture, the symptoms that the, say, child presents with, to understand, does this VUS potentially have a link to that set of symptoms or not? And in those scenarios, then PGTM may not be beneficial for the couple. The second part of our review is a technical review. Depending on the type of variant, there will be different approaches that we can consider for the PGTM test development. We'll consider which samples and which reports are needed to offer PGTM reliably. Many times we don't need to involve relatives, and this can be helpful if we ever need to fast track the PGTM process. So how does all of this work? We really use a multiple detection approach to ensure the most reliable results. The type of testing that you're going to be most used to, the most intuitive way for genetic testing to occur, is direct detection. We have a variant, we want to find it directly. And this is how most genetic testing works in the general genetic space. You receive a blood sample or saliva sample, you can use that to run a whole host of tests. We are preparing to do testing on an embryo biopsy. As you can imagine, we get a very small amount of DNA, maybe 5 or 10 cells per embryo. And so that introduces some challenges in terms of which technologies can truly be used. So there are some types of variants where direct detection would be possible on embryonic DNA. So if you imagine that the variant could be picked up by routine sequencing, most likely we can also detect those variants directly in embryos. But there will be more complex types of variants, deletions or duplications or repeat expansions, where direct detection is not possible. And that's one of the reasons also to use linkage analysis, which can account for the possibility of allele dropout, can increase the accuracy of the test, and reduces the chance of no results or misdiagnosis. So linkage analysis truly is a gold standard for PGTM and is going to be used by every reputable laboratory in one way or another. And here, the informativity of markers is essential and unique to each family. So what is linkage? I want you to think of forensic genetics. On CSI, how do we identify from a blood sample whose DNA that is? We look at a sort of genetic fingerprint. And we know that each individual, let's say with a recessive condition, is the example I'm going to show you, we expect that every person has 2 copies of that gene. And so we want to be able to differentiate them from each other. In the case of PGTM, we expect that they have a variant on 1 copy. We want to identify that genetic fingerprint that's associated with that. We label this the at-risk haplotype, and we want to identify the other gene copy, which we don't expect to see on any variants on, and this would be considered the low-risk haplotype. How do we do this? This really requires 2 generations of information. At a minimum, we would need DNA samples from the egg and sperm source, and then 1 additional generation. There's flexibility here depending on the family structure and the genetic variant of what we can consider. We'll ask about availability of parents of the reproductive couple or any children or prior pregnancies that they've had, and if there's any DNA from those pregnancies. We can equally consider embryo biopsies and DNA from those produced through the IVF cycle. Again, the combination of which, on a technical level, we'll review during that case review stage. So I want to walk you through an example of an autosomal recessive condition, let's say sickle cell anemia, when this is caused by variants in the HBB gene, which lives on chromosome 11. We each have 2 copies of every gene, one which we would have inherited from our mother, the other from our father. And when I'm looking at DNA from just the couple, I can't figure out which is which and where, in this case, their sickle cell anemia variant lives. We want to understand the pieces of the puzzle and what they look like. Now, I've simplified it here to show SDRs in the form of just different colors. And here, a second generation helps because we can separate out those 2 gene copies, because each reproductive pair is only going to pass on one of their gene copies. So right now we have question marks. We don't know where this variant lives on their different gene copies. This couple happens to have an affected child. We can receive his DNA sample and compare, well, what does his fingerprint on chromosome 11 look like compared to his parents? We know that he has this condition. He has 2 variants in this gene. And so we can extrapolate from there. So now we can resolve these question marks. We know then on the paternal side that the gene variant lives on the light purple copy. And on the maternal side, it lives on the light orange copy, for simplicity's sake. This then helps us understand, okay, if we see markers in the light purple genetic fingerprint, that is labeled the at-risk haplotype. Similarly, light orange is labeled as the at-risk haplotype. We've also now established the low-risk haplotypes, dark purple, dark orange. And these are the ones we really want to see in the embryo so that they can be great options for transfer. With all these pieces of the puzzle figured out, now we have a full set of results we can provide. We can identify embryos that are carriers. They have one of the at-risk haplotypes and one low-risk haplotype. We can figure out if embryos are at risk, if they have the same 2 copies as their son. And we can figure out if they are carriers, if maybe they have one, or non-carriers, they have both low-risk haplotypes, both the dark purple and dark orange. Now, I mentioned before, informativity of these markers is really essential. And this informativity is based on how unique each of the different haplotypes is from each other. And what if they aren't so different from each other? This can happen, say, if the couple were consanguineous, if there was a genetic relatedness, say they were first cousins, then they would share a common ancestor, and likely they would share the same at-risk haplotype as well. There are going to be some methods of linkage analysis where this is a limitation and introduces challenges. With the methodology of using short tandem repeats, STRs, these cases are actually quite straightforward for us. The same haplotype that they share is known to be the at-risk haplotype, and the low-risk haplotypes are going to be unique. And so we can pretty easily complete these cases. So all that to say, test development is really unique for each family, even for very, very common variants that we've had completed thousands of times before. Completing that test development really is the step that ensures PGTM is possible. For the vast majority of cases, 2/3, this is completed within 3 weeks, the test development, given that we have a whole host of experience prior with so many of the variants that we encounter. And then there are a subset of variants that may be new to us, and these will take a little bit longer, around 6 weeks, for probe development to be completed. Now, probe development can also be completed after an IVF cycle. These kinds of scenarios where we may need to fast track the whole process come up, unfortunately, or fortunately, rarely, but they can come up in really serious situations. An example that we encounter is where someone needs to go through fertility preservation treatment as soon as possible. They've had a cancer diagnosis, they want to complete IVF, and then get treatment, and then worry about what else do I need to think about. And so they may not complete their genetic testing until after IVF, and then say they're identified to have a BRCA1 variant. There is still the option to offer and consider PGTM. This is called PGTM add-on. Ideally, we want to be able to review the case as soon as possible to give you these insights of what are our options and do we need anything additional. There will also be scenarios where potentially we aren't able to involve relatives. The relatives may be international, and while we can coordinate international kits for relatives, it does add a layer of complexity and time. The couple may want to keep IVF private, or they may not have any other relatives with the same condition if it's a brand new variant in them. And so here we do have this option, like I mentioned earlier, to instead utilize genetic information from embryos to complete test development. Some benefits to this are that it's faster, simpler, really expect to achieve the same 98% accuracy, and it is available for most cases as long as direct detection of the variant is possible in embryos. Here again, that case review will give us that insights to know whether this is an option that we can provide or not. I will make a note that there are some special considerations. We do need a minimum of 4 embryo biopsy samples. And this gives us a range of different genetic results for the embryos to help us establish that at-risk haplotype, like I showed you with the orange and the purple. Now, these 4 embryo biopsies, we can be flexible with it. We know not everyone can get 4 blastocyst embryos for biopsy, so this can include arrested embryos, as provided that DNA quality is good, and importantly, can also include aneuploid embryos, so they don't need to be euploid specifically. There are going to be some limitations to this as well. So I've mentioned direct detection is key for certain genetic variants. So there are scenarios where we may not be able to offer that, where we may rely on genetic information, samples or reports from relatives. So keep an eye out for these kinds of cases: large deletions, duplications, repeat expansion conditions like Fragile X or C9orf27 and Huntington's. I know Dr. Tucker is going to present 2 cases of these conditions. And then there are some genetically complex regions, FSHD, Fox gene telomeric regions. Challenging cases can also include, these milder indications, VUSs, gamete donor cases. Thankfully, have been pretty straightforward to coordinate. Just keep in mind, we do need a DNA sample from the gamete donor for test development. And then some more interesting, exciting options like non-disclosure or HLA matching, which don't quite fit the category of simplified. So I'll leave those for another day. Truly, to ensure patient quality care, this sometimes takes a multidisciplinary effort, especially for some of those more challenging cases. At the bare minimum, every case is going to have a clinical review that's performed by the IVF provider and the clinical and technical review performed by iGenomics. There may be scenarios where we rely on evaluations by a medical geneticist or a specialist, say, in the case of a VUS, or if there's a blood condition, we may involve a hematologist. There may also just be very complex genetic results where outside genetic counseling from a non-iGenomics genetic counselor may be recommended or needed, sometimes for coordination of familial genetic testing when that's required from a technical perspective. There are many different providers and companies that offer genetic counseling in person at your local hospital, and we're happy to provide a link to find a genetic counselor. There are also now a growing number of telegenetics companies that offer remote or online counseling. We're happy to provide a list of referrals and options there to assist and make sure that the patients are getting the right information to help them make a decision about whether they want to pursue PGTM or not. Dr. Tucker actually is a great example of this, and I'm excited for you all to hear more about what she does. Now, I didn't talk much about PGTA, but this can be added on at any point in the process with PGTM. So our most common and default option is going to be that we perform PGTM and PGTA together. This is the fastest option, gets us results in 15 days. There may be other scenarios where PGTA is actually completed first, and then we are combining cycles of PGTA, embryos from cycles run on PGTA, to then run PGTM at the conclusion of those IVF cycles. This can be cost effective, but can also give the patient the chance to learn about PGTA results before deciding if they want to run PGTM or at what point. And then, like I mentioned earlier, this option of adding on PGTM much later, if the need for PGTM is not known until after PGT is completed. So there's flexibility depending on the individual scenario. All that to say, we don't expect you to know or memorize the nuances of every condition and every gene. That's what we're here for. So when in doubt, reach out, send us the reports, the history, whatever information you have, and we can provide that preliminary review so you have that insights to share with your patient as well about what might be needed or if their case is relatively straightforward to offer. And our role as genetic counselors is to simplify this process for patients as well. We give them a lot of checklists and information to refer back to and guide them through the process step by step. Really, our experience is global and expansive, as you've heard, and this helps us get creative and just have a lot of experience to rely on. I'm going to hand it off to Dr. Tucker now to cover some clinical indications for PGTM and give you some really exciting case examples. I'm handing it over to you, Dr. Tucker.
Yeah, thank you, Divya. I would like to thank Vitrolife and iGenomics for this incredible opportunity to connect to all the attendees today. It is my pleasure to collaborate with Dr. Alyssa Snyder and Divya and present to you clinical cases from my practice, Genome Ally, which is a telehealth genetic consultation practice where we help families navigate genetic issues in the context of family building. At Genome Ally, I work with different PGT labs, all of them, and genetic testing labs. I'm invited to speak for different labs, and I'm a speaker and advisor for Natera. This is my disclosure, and also for Cooper Genomics. I've received an honorarium for the talk today, but the cases and all the content of the talk is independent of that. I'm a big advocate for informed decision making, especially when it comes to pre-test genetic counseling. So it's a disclosure that it will feel that we bank heavily on pre-test counseling in our practice. So next slide, please. So the learning objectives of my talk today is to discuss the indications of PGTM, and we'll review clinical case studies to illustrate a range of indications where PGTM is an option. We will talk about like traditional or pediatric indications that present early on in life. We'll talk about serious adult onset conditions, which may appear later in life but have significant implications for the individual or the family. We will also discuss mild conditions or those conditions where there is limited or questionable risk reduction, and discuss how decisions are made of whether or not PGTM is a good option for a family with such a condition. We'll also talk about like indications where PGTM is not recommended because of a variety of reasons. And then finally, I'll highlight the patient-centered approach that we use at Genome Ally for genetic consultation. This approach basically ensures that families are well equipped with the information they need to make the best decisions for their reproductive health and family building. Next slide. So I'm sure in your practices as clinicians and medical providers, you've seen an increase in PGTM cases over the last several years. This is an abstract that was presented in 2021, where a center in New York presented their experience with increase in cases. They had seen a 2.5-time increase in total PGTM cases and a 5-time increase in PGTM for hereditary cancers. And in the abstract, as you see, there's all the different conditions that were their primary indications for PGTM requests. And mainly what it highlights is the fact that technology has improved for genetic testing, and this allows us to test for different genetic conditions with high accuracy. So if you look at the graph here, the hereditary cancer testing has increased, and so has cardiogenetics over the last several years. And this allows more families to get a diagnosis based on their genetic condition, and then they can make decisions earlier. So this helps them and prevent genetic issues during pregnancy. And this trend in increase in genetic testing has made it more accessible for patients to discuss reproductive options before an affected pregnancy is there. And addressing this, next slide, ASRM basically came out with guidance. So this is a wonderful resource for clinical teams that are offering PGTM. The committee opinion talks about the different indications and management and is a great resource. Next slide. So as we all know, PGTM has been traditionally offered for childhood onset conditions. These conditions are usually severe, often lethal, and have no effective treatment available. Most of these conditions are inherited metabolic conditions where, because of the deficiency of a certain enzyme in an inherited risk, there is a deficiency of a protein product, or there is an excess of a protein product. And we all know such examples such as sickle cell disease, and that leads to severe pain and organ damage, or Tay-Sachs disease, that is a neurodegenerative condition, causes severe cognitive and physical decline in the individual, spinal muscular atrophy, which is a progressive muscle weakness and respiratory failure, or classic cystic fibrosis that leads to severe lung or digestive issues. Increasingly in the last decade or so, we have seen increased genetic testing for childhood cancers and for blindness. And these conditions are devastating. They lack effective treatment. So PGTM is offered quite commonly, and it's increasingly being offered for these conditions. So I want to illustrate this with an example. Next slide. So this is a case that we saw at Chino Malai. A young couple approached us. They had previously given birth to a child at 34 weeks. It was a natural conception. The pregnancy was complicated by preterm labor and polyhydramnios. Other than that, all the ultrasounds and everything had been normal in the pregnancy. And the newborn after birth was found to have profound hypotonia, required intubation, was admitted to the neonatal ICU, and then the pediatric genetic team did a whole exome sequencing for the baby and found that it had homozygous for pathogenic variants in the GBE1 gene. This gene change or mutation causes glycogen storage disease type 4, and eventually the baby passed away at 2 months of age and in the NICU due to severe progressive cardiopulmonary compromise. And this was because the type of glycogen storage disease 4 that the baby had was fatal perinatal neuromuscular subtype. So now this couple wanted to plan their next pregnancy, and their parental testing showed that they are carriers of the same GBE1 pathogenic variant that the baby had. So there is a reproductive risk in this condition. It's a severe condition, and the reproductive risk is 1 in 4, or 25% of the offsprings would be affected in a future pregnancy. So in this case, PGTM was offered as an option, and the couple has gone through IVF now and done the testing of the embryos and is currently pregnant with an unaffected embryo. So this is a typical case that you will see in your practice. However, increasingly we are seeing PGTM request for severe adult onset conditions. So these are adult onset conditions. They don't affect children necessarily, but these conditions do not have usually an effective intervention, or when interventions are available, they are inadequate or highly burdensome for the family or the patient. So these conditions usually you've seen as like inherited cancer risk. So hereditary breast and ovarian cancer syndrome is one of the commonest indications for PGTM, and a lot of families request this testing on the embryos. And these, as you know, this condition, the lifespan of the individual is not affected. However, the burden or the risk for cancers is very high. And the interventions that are required, so in say for example BRCA1 or 2, if the individual carries that pathogenic variant in one of these genes, they are at very high risk for like breast and ovarian cancer. The surgeries for these risk reduction are very burdensome, so they require either bilateral mastectomy or oophorectomy or a combination of both for risk reduction. And in these cases, PGTM can be one of the options for an individual that is at risk for these conditions that does not want to pass that risk on to the embryo. Other conditions where adult onset conditions are a valid indication for PGTM and are offered as a reproductive option are neurodegenerative conditions such as Huntington's disease or hereditary hypertrophic cardiomyopathy. In this disorder, you know, there is sudden cardiac event. One of the family members is detected with the hypertrophic cardiomyopathy, and if the genetic test picks up that there is a genetic mutation that is being passed on in the different generations in the family, then the family does have a reproductive risk and they can be offered PGTM as an option. So to highlight this case, this indication, I would want to show you a case. Next slide. So this couple reached out to us where they were fairly young. The male partner had a strong family history of C9orf72, which is a gene, and the mutation in their family caused frontotemporal dementia and amyotrophic lateral sclerosis. So this is a devastating condition where there is both upper neuron and lower motor neuron disease. And as you can see in the family, it took them a long time to figure out that there is a genetic risk in the family. The male partner's mother passed away from features of amyotrophic lateral sclerosis, but her decline was really fast, so she couldn't get any genetic testing before she passed away. Then soon after that, an uncle passed away with features of frontotemporal dementia. Again, genetic testing was not done. But then their youngest uncle, he basically started to develop dementia, and then a provider basically did testing for him, identified the genetic mutation in the family. And then the two sons of the affected woman were tested, and the male partner was tested positive while his brother tested negative. So now this couple wants to pursue PGTM, and based on like the mechanism of disease in the family, it's a valid indication, and they a good indication for PGTM. So in the last two cases that I showed are the bulk of the cases that you will see. Either it will be like a pediatric onset condition, which is severe, or a serious adult onset condition. But many a times we will get in, a referral for consideration of PGTM for other indications. So in the next slide, we will discuss the mild conditions or indications where special consideration is to be placed, and we have to like review the case on a case-to-case basis and make the decision that is best suited for the family. So some of the conditions which are mild, and you can get a request from a family for PGTM for such cases, is like low penetrance or susceptibility genes. So one example of that is the ApoE4 gene, which is the susceptibility gene for late onset Alzheimer's disease, or ankylosing spondylitis, HLA-B27 gene, or the factor V Leiden, or the prothrombin thrombophilia gene, the factor 2 or F factor 5. So these susceptibility genes no doubt cause disease in the family, but they also have multiple modifier genes, and also they have like environmental environment makes a difference. So in these families, where there is risk from these genes, the decision to do PGTM has to be carefully considered, and that's what we help families go through the information that's available about the disorder and what they are actually trying to achieve in their family building goal. Another good example of mild condition is the 5T variant. As you all know, that for cystic fibrosis, 5T variant can be of significance if it's associated with like other severe variants in the CFTR gene. It can cause several different manifestations. And so whenever there is a request made for the 5T allele, we have to look at all the data and the genetic testing for that couple and then assess the reproductive risk, and then move forward with the decision of whether or not PGTM is a good option for that family. Next slide. A similar situation would be autosomal recessive conditions where carriers have manifestations. So for example, ataxia telangiectasia is a condition. It's an autosomal recessive condition where if the individual is homozygous for mutations in the ATM gene, they will be severely affected as a child and would have multiple manifestations. Of course, PGTM is a valid indication for that situation, but if there is an autosomal recessive condition like ATM and the carrier is at risk, so women who are carriers for ATM mutation are at risk higher than normal risk of breast cancer. Similarly, if there is a mutation in the GBA gene called Gaucher disease, they do not have a reproductive risk, but they have a risk of Parkinsonism. And then basically what we have to do is to sit down with the family, help them understand the risk and also what it could mean to have affected embryos, because why these families are doing PGTM is to not have a child affected by the condition, but because these conditions are late onset and sometimes milder and sometimes the risk is not well defined, if they have embryos that are eventually the affected embryos, but they're affected by this milder conditions and there is no other embryos that are low risk for the condition, then the families might start to consider to transfer these embryos. And so we have to put all those scenarios in front of them before they embark on the test development for PGTM and talk to them and see if this is a good option for them. Other conditions where special consideration is required is like mild or commonly treated conditions like hereditary hemochromatosis. So in these conditions, usually PGTM is not a good option as a reproductive option. However, there are two other scenarios. One is like a variant where the mutation or the disease where the mutation happened in an affected child, but it's not an inherited risk. We call these de novo mutations. So basically, they're not inherited from an affected parent or at-risk parent, but like this case highlights that these are conditions where it affected a child. So this young couple approached us. They had recently terminated a pregnancy because there was multiple brain malformations and also a bleed in the brain. And that testing of that pregnancy showed that there was a de novo likely pathogenic variant in the COL4A1 gene. The variant was not identified in either parent. The parents had really gone through a difficult time with the loss of the pregnancy, and they wanted to ensure that there is no future risk to the pregnancy. So in all of these autosomal conditions, there is always a risk, a small but yet a known risk of gonadal mosaicism. And there is cases where a repeat pregnancy can be affected. When this information is discussed with the couple, they really want to reduce the risk for the next pregnancy to be affected by this same condition. However, when we review their case, we talk to them and we talk about how low the recurrence risk is. And there is a lack of an established at-risk haplotype. So how Divya mentioned that we need another generation with the same kind of at-risk haplotype to establish linkage. So in these cases, if the case is considered for PGTM, we have to talk to the family that there is an increased chance of multiple embryos that will be excluded from the transfer. And based on the patient's decision making, they may or may not proceed with PGTM. So in this case, PGTM was performed by iGenomics based on an appeal process, and they moved forward with that next step. Next slide. Another such scenario is a variant of uncertain significance. So basically, as you all know, variants of uncertain significance are mutations that are found in genes that are important, but they are not, the mutation is not sufficient. There is no evidence to classify it as pathogenic, that means disease causing, or benign. So in a situation like that, where a mutation has been found, but we don't clearly know whether it's associated with the disease or not, sometimes the family will request that the PGTM is an option that they want to consider. But what we do with them is to sit down with the family and understand, based on the test results, coordinating with the care team and finding out if the phenotype in the family actually makes sense to be associated with the VUS. And then we talk to the family that the test, the PGTM test, will be identifying only the variants present, but it will not reduce the risk for the condition if there are other causes. So sometimes family will say that the variant is what is causing the disease, but because of how genetic diseases happen, there could be another cause that can actually still cause disease in the offspring, and we are falsely reassuring ourselves and the family that the VUS is the one that's causing the disease. So in that situation, the family has to decide whether they want to proceed with this or not. And also many a time studies have shown that VUSs can eventually be classified as benign. And if that happens, and we've already tested embryos for PGTM and decisions have been taken based on those information, the family should not feel regret that they did testing for a variant of uncertain significance. I want to remind all the attendees that PGTM labs have specific policies for how they handle VUS. They collect evidence, they want to know if there is a recurrence risk and what the patient preference is and what is the end goal for the family. So it's always good to check out with the PGT lab. Next slide. Now, there are some indications where PGTM is not recommended. We all know that PGTM is not recommended for autosomal recessive carrier status without manifestations. Sometimes families will approach us and then we just have to educate them and say that there is no reproductive risk and it's okay to be a carrier. Other times it's a combination of variants that are pathogenic, that are a mutation, but a homozygosity for those variants do not cause disease. A common example is the homozygosity for biotinidase deficiency variant D444H. If a couple is at risk for this or is homozygous for this disorder, there will not be a disease for biotinidase deficiency. Similarly, nephrotic syndrome type 2 variant, R229Q does not require PGTM. Silent carriers, as Divya mentioned, for alpha thalassemia, do not require PGTM. And then galactosemia, a certain variant of galactosemia, Duarte variant, they do not have reproductive risk, and therefore PGTM is not a good option for them. Next slide. Another category where this is not required is the pseudodeficiency alleles. From time to time on carrier screening, we identify pseudodeficiency alleles. So basically these are mutations in certain genes, commonly in the GAA or the GALT gene or the hexa gene. Basically, these do not cause a difference in protein production or gene expression. The mutation is there, but it doesn't change anything, and so PGTM will not be required for them. And another specific scenario is when a tumor in an individual is tested and a somatic variant or a genetic change is found in the tumor, but the germline testing does not show the mutation, then PGTM is not recommended. So for these families where a tumor testing has been done and we get this request from time to time, we would actually do the germline testing. Many a times they don't even have the germline testing that's done. They would just come in and say, oh, I have BRCA1 mutation or this, but when you look at the test results, it was actually in the tumor. So we will go ahead and order the germline testing. And if it is negative in the germline for that individual, then they don't need to be worried about the reproductive risk to a child, and they don't, PGTM is not recommended. However, there are certain specific conditions where PGTM can help. These are individualized care plans for certain families, and one of them is PGTA HLA. So there are some families that have a child affected by genetic immunodeficiency or hemoglobinopathy. These individuals, the child is like affected severely, needs a stem cell transplantation, and the family is looking for a HLA compatible donor for that stem cell transplantation. Plus, they want to reduce the risk of like the disease in the next child as well. So they don't want the child to be affected by, say, sickle cell anemia is a common example of this, or Diamond-Blackfan syndrome. But on top of that, they also want to like make sure that they have a possibility of a complete HLA match to the affected child. And in these cases, you know, there is a theoretical chance that the embryo, each embryo will have a 1 in 4 chance of being an HLA match. But in reality, due to recombination, typically a 19–20% chance is what is usually there for an embryo to match, and some families might opt for it. Every case that is asking for such kind of indications, you know, we will talk to them and make sure that they understand how this will benefit their family. Another example, next slide, is the hemolytic disease of the newborn. Sometimes a woman who's carrying the pregnancy may become sensitized to blood group antigens like RHD or KEL or NTE sensitization. In those cases, if a future baby is positive for KEL or for the D antigen, there will be an autoimmune disease and the pregnancy can be at risk. The mother might need multiple procedures or be at risk for complications from them. So families sometimes will request this kind of matching. And in this case, you know, antigen genotyping of both the egg and the sperm provider is essential. This is a special type or a subform of PGTM that a number of times might be required. Next slide. Another interesting indication for PGTM is non-disclosure PGTM. So there are some individuals who are at risk for adult onset genetic conditions like Huntington's disease or spinocerebellar ataxia, and they basically will be at risk for the disorder, but they necessarily don't want to know their genetic risk because they consider it as a death sentence. So they want to preserve their right not to know, but they don't want to pass on the disease to the child. Next slide. So this is an example of a family where there was like a disease risk for Huntington's disease. The male partner's maternal grandfather had Huntington's disease. He passed away in his 70s when he was like 81 years old, and the couple did not want to pass the disease to the offspring, but neither the male partner nor his mother wanted to get testing. And for such cases, we have to like do a case-to-case review. We had to like find test results and make sure that this was a good option for this family. Next slide. So this next slide basically summarizes our patient-focused approach that we follow in Genome Ally. So we have to keep the family in the center and see what their family goals are, what they are trying to achieve. Just because the technology to test for a condition is available, it may or may not be a good option for them. Of course, we will like talk about like the condition that they are trying to test for, the timeline, and that family members will be required. But we will also talk about whether or not there will be availability of an embryo. There are some women who have very low egg reserve, and in them, you know, the availability of an embryo that is low risk and is also like euploid for PGTA can be really low, and PGTA and PGTM might not be an option for them. We also talk about the accuracy and follow-up that will be required afterwards, including prenatal testing and counseling. We always talk about how the embryo is such a microscopic structure and we are only taking a few cells out of it, and most families will consider prenatal testing during pregnancy. We also talk about like management of test results, and that brings me to the conclusion of the talk. Next slide. PGTM is a reproductive option, you know, that utilizes assisted reproductive technology. It's a groundbreaking technology. It helps to reduce risk in an offspring. It eradicates disease in family when generation after generation of children and individuals have been affected. You know, it can be performed on a wide range of indications. But what we provide at Genome Ally and what, you know, the team at iGenomics was alluding to, that each family is unique. That test development is unique. We have to individualize the nature of each case. We have to understand what the family is trying to achieve, and then we coordinate their genetic coordination of care. And the services at Genome Ally basically are available to patients through telehealth. So that takes away the barriers, and access is important for us in this day and age. And I'm excited that we are talking about this today, and I want to hand it back to Dr. Snyder and Divya.
Thank you so much, Dr. Thacker. That was amazing. I love all those case presentations and the descriptions of different ways in which we can offer PGTM. And I think you're, highlighting Genome Ally also highlights the way that we like to collaborate on PGTM cases. It really is, as Divya was saying, a multidisciplinary effort. We can't, just test a patient. It involves a really joint effort with many different healthcare providers. So thank you for those of you who have stayed with us this far. We are wrapping up. I've got just a few numbers to share with you, and then we'll open the floor for questions. So one of our most frequently asked questions is, can you do PGTM for whatever condition? And the truth is that almost all of the time we can, but we don't just say yes because of everything that we've discussed today. We have to review the report. A variant in cystic fibrosis is not always a classic indication. Sometimes there can be non-classic cystic fibrosis. So we really have to review the individual variant, and we have to talk with the patient and see what their family situation is. But most of the time the answer is yes. We just hesitate to say that right away because it is a complex process that we have to walk through. iGenomics' PGTM testing is the highest standard in the market with an accuracy of 98%. And we have a very low rate of non-informative embryos that we're not able to get a result for of less than 5%. Not shown here additionally is kind of this question of how often do we fail in being able to perform PGTM testing for a patient. So if we do that pre-PGTM or that test development, how often do we fail in being able to provide results for that? And the answer to that is also less than 1%. So we have a really robust PGTM program. I'm very proud of our team and this webinar that we've presented to you today. I don't see any questions in the chat, but to our audience, if you wanted to type in any questions, then we can bring them to the table and have Divya and Dr. Thacker answer them. You're also welcome to email us afterwards. So we have provided here the contact information for the iGenomics genetic counseling team. So we're kind of the front end of every PGTM case. So they are the ones that receive the genetic counseling requests and do this clinical and technical review that Divya was describing. So you're welcome to contact us with any questions. While we're waiting for questions to show up, I'll just ask Divya, do you have a sense of what the most common conditions are for which we perform PGTM?
Yes, we've looked at this just out of curiosity too. As you can imagine, CFTR, HBB, SMA, so spinal muscular atrophy, and then getting up there, as Dr. Thacker alluded to, are cancer conditions like BRCA1 and 2, Fragile X, as to name another one. Probably see those the most.
And what is the most frequently requested PGTM case that you feel shouldn't be requested, where PGTM really doesn't have clinical utility?
Common ones that are just so easy to see on a carrier screening report that looks like it should be flagged as alpha thalassemia silent carriers. And it's so nice then to provide some reassurance. We don't need to think about PGTM. This couple can proceed without the extra layer of coordination and time and money, and without worries about risks to their children.
And obviously I'm biased, but I think that the clinical review that iGenomics offers is really a valuable service. So if we weren't to do that clinical review, we would just receive and test anything that came our way and profit off of that. But I think it shows a lot of integrity that we, provide some feedback to the client when we say, we don't feel like PGTM is going to benefit the patient in this particular situation.
Definitely. I stand by it for sure.
All right, well, that concludes our time today. So again, Divya, thank you so much. Dr. Thacker, thank you so much. Really appreciate working with you and collaborating with you on all of our cases. And again, if anyone has questions, please feel free to send us an email.
Thank you, everyone.
Thank you.
Thank you.